My name is Richard Todd Allen. I'm a board-certified orthopedic surgeon working at UC San Diego Health. I've been in practice now for about 13 and a half years following my fellowship, and my expertise or specialization is reconstructive procedures for adult deformity, scoliosis, tumor, also doing a lot of upper cervical spine and cervical thoracic deformity, both a combination of open and minimally invasive procedures. One feature in looking at the ovine study and then seeing the transition in my practice and the evolution in my practice for use of MagnetOs. When we look at the surface architecture of MagnetOs, this needle grip surface, and we look at the biologically active implants that have altered surface features and architecture that may create a bone response to bone biology and yield fusion that is improved over prior implants. Those implants are placed in under compression, and I think that a feature of the ovine model was that even in an intertransverse space where it's a very challenging biologic environment, it gave me a little more confidence to be able to take that and say, I'm going to use it in these most difficult patients. The hope is that in the higher level studies that MagnetOs is doing, for example, with Project Fusion, and looking at it in a level 1 comparisons with current bone grafts, which have very limited data. 510K pathway data is not necessarily applicable to every patient, particularly the academic patient that has a very limited soft tissue envelope, maybe prior infections in their spine, and now you're trying to improve their quality of life in a very difficult environment. So getting that predictability, I'm hoping that, as we'll see in the future, will be one of the features of MagnetOs that I can say it's going to give me a predictable, reliable fusion despite the environment that's very difficult and challenging to bridge. And I've actually seen that clinically in my patients in revisions and patients who have proximal junctional kyphosis last week. And there's several patients where I feel like I get durability, I get reliable and predictability in terms of my fusion environment. And I'm able to go back on those patients. I correlate what I see intraoperatively with what I see on the CT scan. And I've been really impressed by the bone formation, and in fact this last patient I had MagnetOs in this space at about 8 months out, and I got a CT scan, and it was an adjacent segment proximal junctional failure case, and it was robust. I could see exactly where I put the MagnetOs. I could see the evolution of the granules, and it was robust, it was hard, it was fused. I was impressed in this particular patient by the durability and by the strength of that fusion. And I'm not seeing the broken rods, I'm not seeing the failure of fusions. The fusion bed posteriorly, the vascularity, the soft tissue envelope, as well as the limited amount of bone available for fusion really makes that environment difficult. And having something that I know in its entirety, if I place a bone graft there, to generate that biologic response, give me predictability, give me something that has a biologic track record. I like the way that MagnetOs has a history in the surface architecture modifications, and that's what we've seen in implants and implant biology. And the ability to generate a biologic response at the tissue level is really what I'm looking for in a graft. Those types of features may make it suitable for your practice, or if your practice sees that you need that type of graft option, I think it's a viable alternative to consider.